Welcome, everyone, to this symposium on congenital syphilis. I'm Dr. Phoebe Thorpe from the Division of STD Prevention at CDC, and with me is Dr. Sonali Kulkarni from the Los Angeles County Department of Public Health. We'll be moderating this session. I want to remind you that there is a live Q&A session for this symposium on Friday, September 18th from 4:10 to 4:30. Our first speaker is Dr. Dominika Seidman. Dr. Seidman is an obstetrician gynecologist and assistant professor at the University of California, San Francisco. She co-founded Team Lily, a multidisciplinary prenatal care team based at San Francisco General Hospital for pregnant people experiencing intersecting barriers to care, including homelessness, substance use disorders, mental illness, and incarceration during pregnancy. Her research focuses on integrating sexual health care and prevention strategies into reproductive health services. Welcome, Dr. Seidman.
Thank you very much for the opportunity to present today. I have nothing to disclose. I'm located in California, where over 1/4 of all people experiencing homelessness in the United States live. California also has the highest proportion of unsheltered individuals, meaning people living on the street, in a tent, or in a vehicle. Put another way, over half of all people who are currently unsheltered live in California. Violence is the leading cause of homelessness for cisgender women in the United States, and rates of PTSD are reported at 40%, although anecdotally that feels like a gross underestimation. When we talk about trauma in this population, we must recognize the multitude of intersecting traumas that individuals experience, certainly childhood and partner violence, and also structural traumas such as discrimination and structural racism. In the context of this panel, I wanted to highlight the traumas inflicted by the healthcare system when people present to care and are frankly mistreated. Child removals, when parents and children are separated from their families, and experiences of incarceration, among others. I live and work in San Francisco, which has been identified as one of the capitals of the housing crisis in the US. As you can see in the graph on the left of your screen, the trend of increasing numbers of people experiencing homelessness in San Francisco is mirrored in the initial uptick and now explosion of syphilis cases in cisgender women. These have finally resulted in the return of congenital syphilis to San Francisco. These parallel trends are not merely coincidental and seem to be inextricably linked. Last year, almost 2/3 of syphilis diagnoses in pregnant people were in people experiencing homelessness. Other key themes include use of stimulants, untreated mental illness, history of child protective services removal of children, and minimal, if any, prenatal services received. As a disclosure, I didn't come to this work that I'm presenting today because of a burning desire to work on syphilis. Rather, this work really came out of a deep frustration as an obstetrician working in a public safety net hospital, recognizing that there were many pregnant people coming to our ER or urgent care or labor and delivery triage, and these patients were receiving limited, if any, prenatal care. Anecdotally, there seemed to be a widely shared experience. This seems to be a widely shared experience around the country. And thinking through how to change our system of care to include these patients who are frequently affected by homelessness, substance use, mental illness, and significant trauma at the hands of the healthcare system is really what brings me to this work. In 2018, I co-founded a prenatal care program that's called Team Lily, which is a multidisciplinary care team for pregnant people in San Francisco who are experiencing multiple barriers to care. Our team's comprised of an OBGYN, who is me, a social worker, a navigator, a psychiatrist, and many community partners. I'll tell you more about our program in a moment, but this is how I began working on congenital syphilis prevention. When you look at the congenital syphilis prevention cascade on the right-hand side of your screen, you can see that the first step is receiving any prenatal care within 30 days of birth. That is an incredibly low bar for an assessment of prenatal care services. And the congenital syphilis cascade in San Francisco were all essentially misses at this level in the cascade. What this means is that congenital syphilis is effectively a demonstration of our broken perinatal care system. And in order to eliminate congenital syphilis, we have to think upstream. To give you a snapshot of the patients with whom we work, 95% were experiencing homelessness at entry. Histories of child removal, which women frankly describe as traumas, are very common, as well as substance use disorders. 10% of patients so far have been diagnosed and treated for syphilis. Luckily, we've not had a congenital syphilis case to date. Finally, I want to highlight how even in this very small population, we've seen a high number of maternal deaths, each of which on maternal death review can be directly linked to the structural traumas, including discrimination in healthcare, child removal leading to relapse and overdose, and gun violence. In reflecting on patients' biggest barriers to engaging in prenatal care, what we see mirrors a large study of cisgender women who use drugs in Michigan. This study found that among all of the barriers people face, fear of mistreatment or frank discrimination and fear of child removal are among the most powerful. We address those fears in our team and in our work by thinking a lot about how to practice trauma-informed pregnancy care. You may be wondering again how this links to congenital syphilis. As a reminder, there is a direct link when we consider the congenital syphilis prevention cascade. How do we support engagement in pregnancy care to facilitate the necessary testing and treatment of syphilis? One way to do that, particularly when engaging the most marginalized patients, is to think through every component of care with the lens of trauma. Most important in this exercise is recognizing that almost all of our patients have experienced frank mistreatment or discrimination at the hands of the healthcare system, and this is a form of trauma in and of itself. Therefore, the healthcare system is in and of itself triggering. On top of that, reproductive healthcare may be particularly triggering, either because of history of sexual violence or experiences of prior child removals that were traumatic. Trauma-informed care is really a talk in and of itself, but the basic premise is to welcome and congratulate people for making it in whenever and wherever that happens. We try to be very thoughtful as well about the language that we use, using person-first language. As an example, you may have heard throughout this talk that I use the words people experiencing homelessness rather than homeless people. People are not defined solely by their housing status, and housing status is an ever-changing state. Finally, we aim to provide person-centered care, elevating the needs and priorities of the pregnant person first. I mentioned welcoming people wherever and whenever they present to care. One of my personal pet peeves in pregnancy care is when we label people as having scant or limited prenatal care, but when you look at their chart, they presented to the emergency room 10 times during pregnancy or to urgent cares, or they're dosing at a methadone clinic every single day. We really need to expand our definition of prenatal care and bring services to where people are presenting, and very importantly, ensure that those services, including syphilis testing, are done in a person-centered and trauma-informed way. Our program does a lot of work with all of the collaborators on this screen in order to allow them to contact us when patients do present to care and help guide those care providers in those settings. And also, very importantly, debrief after when we get feedback from patients about how care was experienced. Importantly, in those visits, it's critical to recognize that our medical agenda and the agenda of the patient might be incredibly different. We asked in the past what messages our patients would like to pass on to providers about caring for pregnant people experiencing homelessness. Patients said, "Housing is real and it's hard. That's the biggest thing for everybody out here, to be homeless." Put another way, listen to me and listen to my priorities. And don't try and push anything if someone doesn't agree with you and you push it. They will completely shut down about anything you have to say afterwards. At Team Lily, we really try to live by these messages. Specifically, when someone says that they need to focus on their housing or anything else, that is exactly what we try to do. As one client told me, who had been diagnosed and treated for syphilis, gonorrhea, and chlamydia during her pregnancy, she also declined PrEP and PEP, stating that she just needed to focus on housing right now. After that, everything would fall into place, even her recovery. It took longer than it should have to get her housing. And yet when it happened, just as she had said it would, everything really did fall into place. She was able to stop using meth. She didn't need to practice survival sex anymore. She had a healthy birth and went home with her baby. And importantly, with housing, her structural vulnerabilities to syphilis changed dramatically. She knew her most important way to prevent congenital syphilis was to find a safe place to live. So when we in our medical charting leave homelessness off the problem list or at the bottom, we are really ignoring a critical part of this person's healthcare that's related to syphilis and congenital syphilis, as well as so many other health outcomes. Returning to those central barriers to engagement in pregnancy care we've talked about trauma-informed, person-centered care as a way of overcoming some of the barriers posed by experiences and fears of mistreatment. Fear of child removal is the other key barrier that I wanted to focus on because it comes up so frequently clinically when we're caring for these patients. Whenever I talk to people around the country who are doing this work, it inevitably comes up, and it's very rarely written about and as a contributing factor to congenital syphilis cases. People's fear of child removal is often the single most powerful barrier we face in helping pregnant people experiencing homelessness engage in care. This fear is well-founded. I highly recommend, if you haven't already, read some of Dorothy Roberts' powerful work, suggesting that the Child Protective Services in many ways is an extension of policing, just a way to begin policing of children and families from birth. Those same violent acts that have been all over the news in recent months manifest in different but equally violent ways in child separations and breaking up of families. We hear this from patients every day, and ironically, this fear and expectation leads people being terrified of coming into care because the assumption is that the healthcare system will call Child Protective Services. Because of that, people don't come to prenatal visits or get syphilis testing. And patients are right, the healthcare system does call CPS because we don't incorporate support of people's parenting goals throughout pregnancy. To try and break some of this vicious cycle, our program is formed by principles of reproductive justice. Reproductive justice is a framework developed by a group of Black women theorists as a response to the experience of oppression and injustices that are experienced across the full range of reproductive experiences. Reproductive justice explicitly prioritizes understanding and addressing the intersectional experiences of marginalized communities. Put simply, reproductive justice promotes the idea that humans have a right to have children, to not have children, and to parent in safe communities. In practice, that means in order to promote people's parenting goals, we have to address housing, substance use, mental illness, and a multitude of intersecting barriers to prenatal care. This work is incredibly challenging, both in practice to help find people resources like housing, and in terms of our biases as a community about who has the ability to parent. But what we have found in trying to practice and move and uplift these ideas of reproductive justice is that doing this work has been critical to engaging patients in prenatal care, and in turn, preventing a multitude of poor health outcomes and future traumas. To summarize, social and structural determinants of health seem to drive syphilis diagnoses in cisgender women in San Francisco. Therefore, addressing these health determinants, focusing on housing, food, transportation, and resources remains a critical, if not the most important form of congenital syphilis prevention for cisgender women. So with that, in addition to the congenital syphilis cases that we have averted, I think our most important outcome data are these: focusing on housing, substance use treatment, and prevention of child removals. I think that only by incorporating these upstream factors into our congenital syphilis treatment cascades will we be able to ultimately eliminate congenital syphilis and dramatically improve our perinatal healthcare system. I'd love to be in touch about questions and comments and ideas, and thank you very much.
Our second speaker is Dr. Shaketa Johnson. Dr. Johnson is Deputy Director of Operations with the Louisiana STD/HIV Hepatitis Program. In this capacity, she's responsible for assisting with the oversight of statewide STD, HIV, and viral hepatitis program activities, and offers program-related clinical consultation to internal and external partners. She has more than 18 years of experience with the Louisiana Office of Public Health. She will be speaking on the Louisiana SHOT program, in-home syphilis testing and treatment program.
Thank you, Sonali, and thank you to the conference planners for inviting us to speak on our our Louisiana SHOT program. We're always excited to share our experience here in Louisiana and hopefully learn from our colleagues and the work that you all are doing around congenital syphilis prevention. So thank you very much. So to get started, we'll take a look at congenital syphilis in Louisiana compared to our rates in the state and other parts of the country. You see that in Louisiana, we have a significantly higher morbidity in the state versus other jurisdictions. And this is true for other southern states that you can see around us. Our congenital syphilis rates in Louisiana tend to be higher than those in other parts of the state, as well as the national average. You'll see that we did have a decrease in 2016 and 2018. And we realized those decreases because there was a very aggressive campaign to reduce not only our congenital syphilis rates, but syphilis across the state. Congenital syphilis on this graph, looking at the 10-year trend, you'll see that our reported cases by year of birth have continued to increase, as well as the rates of reported cases of primary and secondary syphilis among females in the age group of 15 to 44. This is true not just for us, I think, but it's a trend that we see happening in other states as well across the country. Giving you a snapshot of primary and secondary syphilis in Louisiana, you'll see that our syphilis is pretty well distributed across the state, but we do have some high morbidity areas in some of our more metropolitan areas. Louisiana has a largely rural, low population density outside of major cities. So we have some very rural populations. There's poor transportation infrastructure in those more rural parts of the state. We do have bus lines in like New Orleans or Shreveport and perhaps Baton Rouge, but the majority of the state does not have public transportation. And there are several areas that don't offer ride-sharing services like Uber and Lyft and things like that as well. So there is really a deficit in the area of transportation in most of the state. 19 to 20% is our overall poverty rate. So we have significant poverty across the state, with that being recognized amongst our people of color, with almost 33% of African Americans living below the poverty line. In 2016, we were very fortunate with Governor John Bel Edwards taking office, and he expanded Medicaid as his first order of business. And with that expansion of Medicaid, we increased the number of people covered by Medicaid by 480,000 adults. So it really did impact the number of individuals who had insurance coverage in our state. Louisiana ranks 45th among other states in reported births with 15 to 19-year-old females. So we do have a significant problem with teenage pregnancy as well in our states. If you look at this map, you'll see how our state is broken up into Office of Public Health administrative regions. And I want you to pay close attention to Region 1, which is New Orleans, Region 2, Baton Rouge, which is our capital city area, Region 7, which is Shreveport, and also Region 4, Lafayette. When you look at our congenital syphilis cases by geographic distribution, you see that there was at least one case of congenital syphilis in all 9 of our Office of Public Health regions. Historically, we've had our congenital syphilis cases concentrated in our more metropolitan areas, Shreveport, New Orleans, Baton Rouge, but now we see that we have a more broader distribution of those cases across the state. So this tells us that not only do we focus on our more concentrated regions when it comes to congenital syphilis prevention, we definitely need to leverage our activities across the state and make sure that we're reaching all those who are in need of our services. When we break down the number of cases we had in 2018, we had 43 cases. And if you pay close attention, we had almost 77% of those cases being African-American women giving birth to babies diagnosed with congenital syphilis. And you also know that they were young, between the ages of 20 to 29. We're talking roughly about 67% of those cases. And, you know, with health disparities across the country, we also see that there's an issue within our state with health disparities and access to care. So this is just an extension of what we see as a larger problem in the state with access to care. Medicaid did assist with this, and we're also very happy to report that most of our women are actually seeking prenatal care and attending those prenatal visits. But even though they're seeking care and getting those prenatal visits, they're still being diagnosed, having children diagnosed with congenital syphilis. So there's a deeper problem that we have to continue to examine. Also, one caveat that we found was that 83, almost 84% of the cases were covered by public or government insurance, which for us is primarily Medicaid. So that gave us a population to target with regards to provider education and outreach efforts. Here you see, again, a breakdown of our prenatal visits. So you see the majority of the women who had congenital syphilis births did have anywhere from 5 to 14 prenatal care visits. So they were accessing care. So the question is, why didn't they achieve adequate treatment in time to prevent a congenital syphilis birth? Well, in Louisiana, we've seen that this problem of congenital syphilis has been an issue for many years, going all the way back to before 2007. But in 2007, there was a state law enacted to require every physician attending a pregnant woman to offer syphilis and HIV tests at the first exam during pregnancy, so their first prenatal visit. And when we really looked at the data of Medicaid providers, we saw that that was happening on a pretty frequent basis, anywhere from 50 to 70%. Women were having syphilis and HIV testing on the first prenatal visit. However, we saw that there were issues with women having a repeat test in the third trimester, which is advised by CDC if you're a high morbidity state, which we are. So in 2014, we took that law a step further and we enacted the third trimester testing law. And this required that women are tested during the third trimester of testing, as well as on that first prenatal visit, and also receive testing if they deliver and their status is not recorded on the record. And just to give you a timeline of our overall response to congenital syphilis and STD overall, in 2011, we established regional STD task forces in very high prevalence OPH regions. So Region 7, Shreveport, was our first area to have a regional STD task force. And that was in response to a congenital syphilis and syphilis outbreak that required the CDC to come in and do a rapid ethnographic assessment. And during that assessment, what was seen to be very helpful was a campaign that involved not just the public health team, but also it engaged our community partners and private providers. We did see a significant decrease in the number of congenital syphilis cases as a result of that task force effort. So in 2016, we decided to expand that concept to other parts of the state. So we formed a regional STD task force in each region of the state. Also, we saw that there was a need to do some more deep dives into our congenital syphilis cases. And so we established regional congenital syphilis case review boards in each of the 9 regions as well to assess those contributing factors and identify potential interventions. And in 2018, we were fortunate to receive enhanced congenital syphilis funds as a part of the CDC app's enhanced congenital syphilis funding. And without those funds, we were able to hire case managers in 2 of our high morbidity regions, our capital area, Region 2, Baton Rouge, and in Shreveport. And those case managers assist pregnant women with obtaining treatment and other services. And what we found is that they were not just helping pregnant women, but also they were able to help women of childbearing age who were diagnosed with syphilis as well to seek treatment and also reproductive health services. So they really did, the case managers have really been a great addition to our program. As a part of those enhanced congenital syphilis funds, we were also able to hire a congenital syphilis nurse educator to provide targeted provider education and increase provider awareness across Louisiana of Louisiana screening regulations and encourage adherence to CDC recommended screening and treatment guidelines. Because what we were finding in those case reviews is that providers were sometimes treating patients if they were diagnosed with, say, latent syphilis. They were not treating them appropriately, say with 1 dose of bacillin versus 3 doses, if that was appropriate. There was really a lack of knowledge when it came to private providers with regards to syphilis treatment. So our CDC nurse educator did an outstanding job of creating a provider education curriculum, as well as some targeted provider awareness and education materials that we've been able to distribute across the state and also share with other jurisdictions. We hosted 2 congenital syphilis conferences with the help of Denver Prevention Training Center, and we focused those efforts, our conferences in Baton Rouge, as well as in Shreveport, because what we were also finding through the case reviews is that our epidemics looked a little bit different, and the needs of the state looked different in Baton Rouge versus Shreveport with regards to provider education. And so sometimes there was also a barrier with travel for private providers to be able to leave like the northern part of the state to travel to a conference in other parts of the state. So we thought it was very useful to do this conference in 2 separate areas. And we found that we had great attendance. We had over 100 attendees at both conferences, and we had great responses. And it really did increase the awareness and visibility of the congenital syphilis problem across the state. And in 2019, I'm very proud to say we implemented the SHOT and SHIP Directs program, which are bacillin delivery programs. And our SHOT program, which SHOT stands for Syphilis Home Observed Treatment Program, actually provides home observed treatment to women who may be diagnosed with syphilis but express that they have issues with transportation or childcare. And if they fail their first appointment, we offer this service. And one thing about the SHOT program, why we decided that syphilis home observed treatment would be a useful program here in our state. For many years, like I said, Louisiana has ranked #1 in the nation for congenital syphilis and among the top 3 states for primary and secondary syphilis. And when we implemented the congenital syphilis case review boards, we continue to see, just as recurring barriers to treatment, access to treatment, late-term infections and reinfections, and then inadequate treatment among women who were pregnant. And our goals for the program were to assure appropriate treatment for syphilis infection, to decrease the overall congenital syphilis rate in Louisiana, and decrease transmission of syphilis in individuals who are partners of women who are diagnosed with congenital syphilis, and to decrease syphilis morbidity and mortality overall in the state of Louisiana. We piloted the program in Regions 4, which is Lafayette, Region 6, Alexandria, and Region 7, Shreveport, for pregnant women and their partners. Eligible patients had to have no history of penicillin allergy, and for women who were pregnant, they could have no complications or history of complications with that pregnancy. The patients needed to have access to a working telephone line or cell service and availability of 911 or EMS services in cases of anaphylactic reactions. Home visits were conducted by STD parish health unit nurses or clinic nurses, as well as a DIS or ACS case manager, there was one available. The development of the program was really facilitated by the fact that STD trained nurses in the Office of Public Health here in Louisiana do have the ability to have an expanded role, and they're able to treat based on a syndromic assessment and standing orders we've established and that have been approved by our state STD medical director. The program was a collaborative effort. We got input from our regional medical directors, our regional nurse managers, our DIS supervisors, as well as central office staff, the statewide nurse consultants, STD nurses, and DIS. So it was truly a collaborative effort in developing the program. So that, I think, helped with the buy-in of staff as well. On our task list, we had to develop policies, protocols for nursing, DIS, the pharmacy staff, as well as the lab. We developed patient consent forms, provider and patient-facing materials to promote the program. We developed a supply list and created an actual bag for the nurses to take out when they went on these visits. We developed a training module and did web-based webinars for the staff so that we could reach all the staff at one time, and they could then ask questions and hear the same information. So we thought that was a great time for each of them to learn from each other. And we did quarterly calls as well as a follow-up once we implemented the program. We created evaluation tools both for the staff as well as the patients who were participating in the program to get feedback on how this was working, as well as we developed an outreach plan so we could both engage not just providers and the patients, but also the community to let them know that this program was available. And if you take a look at the timeline, we started in fall of 2018 with this project. We received funding from Louisiana for the program. We formed a multidisciplinary committee to develop the protocols, the consents, medical record templates, the lab procedures, patient education materials, as well as the training program. January 2019, we held our first SHOT training webinar, which was attended by all of the SHOT pilot regions, the regional nurses, the regional medical directors, as well as the DIS staff who will be participating, and also the clerical staff, because they would be assisting with our medical records input with the data and the patient information. By February 2019, our CS nurse educator began making on-site visits to the pilot regions to offer support and technical assistance to make sure that things were flowing smoothly with the program and allow them to answer questions and work through any issues they may have. In March and April of 2019, we started to evaluate the process. We looked at the process as well as how it was working for the staff and the patients, and we used this project as a targeted evaluation project or a TEP for our CDC. And just pushing forward, between February and May, the SHOT program started to receive referrals, and we could receive referrals from private providers, from the parish health units, or from the DIS. The SHOT outreach materials were submitted because they did have to have approval from our health department, Bureau of Media and Communications, and it was approved. And by June of 19, our outreach plan was developed, and we started to implement by October. And ongoing, we continue to look at our referral process, women who are referred to the program, as well as their partners. And we evaluate the efficacy of the SHOT program for expansion to other regions. The following couple of slides are some of the outreach materials we developed. And you'll see here we developed a postcard, which is easy to share with private providers, as well as with some of our health departments or health clinics. This is one of the patient education cards that we left in the offices, the doctor's offices, which we thought was pretty user-friendly, very direct. It was colorful. It was describing the program in a very concise manner. Like I said, again, it was approved by our Bureau of Media and Communications for wide distribution. This is a patient sheet that patients who are involved in the SHOT program received during the home visit. And it really does go into detail as to why congenital syphilis is such a problem in the state, why it's important to get treated, and also education about reinfection and the importance of the partner being treated. And some of the positive outcomes of the program, we increased awareness of the need for timely treatment and the importance of engaging pregnant women in prenatal care. It was an opportunity for the parish health unit nurses and DIS to have one-on-one collaboration and work more closely together. So that really did build those relationships. The patients were opting to go out to parish health units or community providers for treatment as opposed to having a home visit, which is something we didn't anticipate. But we really did see this as an opportunity for increased education. And we didn't see it as a discouraging thing. We didn't necessarily see as many SHOT home visits as we would like, but we were able to get those women in for treatment as soon as possible after they had the more enhanced communication with the DIS or the nurse regarding the home visit. We had opportunities for collaboration with patients, community providers, SHIP leadership, and staff on developing this particular program, so there was increased engagement in that way on a state and regional level, so that's always useful. And timely home treatment of pregnant women prevented several CS cases, and we were very pleased about it. Some of the challenges, however, were collecting data on patients that were considered for the program but not necessarily treated. So we found, like I said, that there were many women that DIS or the nurse may speak to, and she may, once they provided the extra education on why it was so important to get treated, she just decided to make an appointment with the private provider or at the health unit, and she did follow up with that appointment. So there was some difficulty in collecting data on those particular patients because there may have been some ambiguity as to whether or not it was a true referral or not in some cases. There were limited opportunities for parish health unit nurses to conduct home visits, so they weren't able to get as much experience and become as comfortable with the home visit when that was somewhat outside of their traditional role, working in the clinic setting. So that in itself was a barrier. But we did find that using or identifying one particular nurse per clinic who would be engaged with the SHOT program was useful, as opposed to trying to do a broader education with all of the nurses, expecting all of them to have the capacity to do it, but just focusing in on one nurse as a SHOT nurse and working with the DIS seemed to work a little bit better. Competing demands for staff time. In our parish health unit settings, all of our nurses are cross-trained to work across all programs. So we didn't necessarily have a nurse that was dedicated to the SHOT program or congenital syphilis prevention or STD. So that nurse, those parish health unit nurses, had to work the whole clinic and then schedule time to be able to make the SHOT visit if there was a need for one. So coordinating schedules sometimes with those competing demands could prove challenging in different cases. And there was also an issue, again, of staff buy-in, because some nurses were not as willing to go into the home setting. So we found that just identifying one or two nurses per clinic who was willing to make those home visits and participate with the program was more useful than trying to do a broad education or training with all of the nurses on the program. And I'd like to thank Marian Deming, who was our SHIP congenital syphilis nurse educator, as she was very instrumental in working on this program and helping us to develop the policies and procedures in the training module. And Marian was absolutely wonderful. And we lost our funding for her. We had to say goodbye to her. Actually, today was her last day. But she was an integral part of this program, and we can't say enough how much we thank her for the work she did. And all of our SHOT program team members. I'd just like to thank them. And that concludes my program. Thank you.
Dr. Phillip is the Deputy Health Officer and Director of the Disease Control and Prevention Branch in the Population Health Division of the San Francisco Department of Public Health. She is also the STD controller for the city and county of San Francisco. Dr. Phillip is an assistant clinical professor of medicine in the Division of Infectious Diseases at the University of California, San Francisco, and is an HIV primary care provider at the San Francisco City Clinic. And she'll be speaking on using the incident command system to prevent congenital syphilis. Thank you.
Thank you so much for the introduction, and thank you so much to the organizers for inviting me to share some of the experience that we've had in San Francisco using ICS for congenital syphilis prevention. So just as a quick outline, I'm going to give a little bit of the context of congenital syphilis in San Francisco, some of which you've heard really nicely already from Dr. Seidman. I'm going to talk a little bit about an orientation very briefly to what ICS is, some of the accomplishments we had in San Francisco via ICS, and then some lessons learned and next steps that we're considering. So to set the context for this work, while men continue to comprise over 90% of syphilis cases in San Francisco, the number of cases of women have been increasing. So from 2017 to 2018, and again, these are the data that we were looking at when we were making the decision about whether to activate our Department Operations Center and use ICS, our number of cases had increased from 140% from 2017 to 18. And while we didn't have any congenital syphilis case in 2018, we saw that women with syphilis were having multiple vulnerabilities. 31% were experiencing homelessness, 37% reported methamphetamine use, and 32% were diagnosed within our clinical safety net health system, the delivery arm of the San Francisco Department of Public Health's clinical services. Furthermore, when we looked at the racial and ethnic breakdown, Black African American women had disproportionately high percentage of cases of syphilis, and they were rising. And Black African American health is a key component of our DPH focus, and it is one of our true north pillars of health equity for the city and county of San Francisco. So for all of these reasons, this issue of preventing syphilis in women and congenital syphilis, moreover, became such an important issue. Then the structure of our department also led to our thinking around the idea of using the incident command structure. This is only a partial view of our Department of Public Health org chart, but what you can see in the center there is the San Francisco Health Network. This is the care delivery side of DPH. It includes our acute care hospital, Zuckerberg San Francisco General, but also our ambulatory care settings, including jail health, primary care. We have a very highly renowned street medicine program, and maternal, child, and adolescent health. In the population health division, that is where I work. I direct the disease prevention and control branch shown there. And we also have some clinical services within population health. Our goal in our division is to serve the entirety of the city. And City Clinic, our sexual health and STD clinic, is located within disease prevention and control, as is all of our disease intervention specialist work across all communicable diseases. The Applied Research, Community Health, and Epidemiology branch holds all of our epidemiologists and our data scientists. And the Community Health, Equity, and Prevention branch are the experts in working with community-based organizations and engaging that important piece of our work citywide. Our colleagues in the Public Health, Emergency Preparedness, and Response branch are really the experts at ICS and public health response across all hazards. So these were all key partners in thinking about this work, along with the entire leadership of the Department of Public Health and the Director of Health. So it's really, as I said, our colleagues in the Public Health Emergency Preparedness and Response branch, or FEPR, that are the experts on doing this, using the structure of incident command. It was first used in California in the 1970s for wildfire response. Really, the recognition that there were multiple agencies, people were over-responding to one area, under-responding to another, and there just wasn't a coordinated effort that was needed in a very complex, high-stress, high-stakes environment. It is very tightly structured with collective objectives and a very clear chain of command. We have, at the Department of Public Health in San Francisco, activated our Department Operations Center under ICS for prior communicable disease emergencies, including Ebola preparedness, Hepatitis A, and Zika, but we've never done this for STD prevention before. The power of ICS, in a way, one of the powers of ICS is that it puts some subject matter experts into roles, but also the structured information flow and the chain of command allows for non-STD subject matter experts to also serve in key roles, which serves a couple of purposes. It brings in people into closer understanding of the core issues, and it brings more people into owning the solutions and working together to try and address this complex issue. And it also allows the subject matter experts to really be able to focus as key consultants, aiding in the response rather than trying to run the entirety of it in a very large way. So throughout the activation, the incident commander, as you see here, that person's role and that group's role is to really take in all the information, create the strategy, create the plans for each set period of time. And for our initial activation period, we picked a 12-week initial activation period, and then that was repeated for a second 12 weeks. And then you see the other key sections that usually make up incident command. Operations section is the section that actually carries out most of the work and the intervention and the response activities. The planning section incorporates all of the data. It outlines what has been done and what is going to be planned in the next period, and relays that information up to the incident commander so that that group can then continue to make the plan, set the strategy and the priorities. Logistics section is really there to help operations do what it needs to do. It provides all the materials, personnel, other equipment that is needed for the response. And then finance and administration section are there to document the expenses to help facilitate purchases and other financial transactions that need to happen to make everything work. So throughout the activation, the incident commander was never an STD subject matter expert, actually. It altered between being the public health emergency preparedness and response director and deputy director. It has been the director of our health equity group at the Department of Public Health, and the director of health also served as incident commander as well. I served as operations section chief for the entirety of the activation. So I'm going to dive a little bit into that section here so you can see. Under that section, there are multiple branches, including information and guidance, care coordination, medical branch, epi and surveillance, and the laboratory branch. And within these branches, this is where there were some of our STD subject matter experts from City Clinic, from elsewhere in our department and in our division embedded, but along with other colleagues who were not subject matter experts. So it really shared the effort, and Dr. Seidman was really an excellent member of our medical branch as part of the activation as well. So a lot of expertise, but also we were able to have a lot of hands sharing in the work and moving it forward, which was amazing. Another real strength of ICS is that there's a very standard and structured documentation process. Every week, we're reporting up what our accomplishments were and what our objectives are for the next period. That then gets rolled into an overall incident action plan. The data from each branch gets rolled up. This is shared with incident command that approves it. And then we've set our documentation for what we've done, and then also our planning for the next period. And that really helped us see what was happening from week to week. And then as staff transitioned, it also allowed for a more seamless maintenance of the work and moving forward. So the timeline that we had was in early spring, in Q1, we were looking at the data that were just shared and had an initial discussion internally, and then with our health officer in San Francisco, Dr. Tomas Aragon, and made a decision for partial activation. So we didn't have hundreds of people in the activation, but we did have the branches that you saw just previously, and the sections. On May 22nd, before we had officially activated, we did send out a health alert to providers, and you see a snippet of that there, really alerting them about the data that we were seeing and to alert them to rising rates of syphilis among pregnant women. June 3rd was the first date of our activation period 1, that initial 12-week activation period. And there were multiple activities that happened throughout that activation period. But the one I wanted to call out was this was our first multidisciplinary case conference following a case of congenital syphilis, which I think was very, very helpful in bringing, again, a lot of subject matter experts together and a lot of key leaders of different areas of our health system and the rest of the Department of Public Health in order to talk through what we might be able to do better, missed opportunities and bright spots that we could try to learn from. And then in September 4th, we started activation period 2. One of the outcomes from our activation was really the excellent work of our epidemiologists to really be able to distill and share very, very complex and dense information in a way that really helped our colleagues, our non-subject matter expert colleagues, and our leadership, both within the health department and beyond, understand some of the epidemiology much better. So this is a really dense slide, which I want to walk through for just a moment. It was created by one of our outstanding STD epidemiologists, Hannah Brosnan, and she developed this throughout the activation. And as we said, it was very, very helpful. So what you see in the top row there are, and this was just 2018 through the third quarter of 2019. You see the women who were pregnant and diagnosed with syphilis in 2018 or 2019. There were 7 in 2018 and 6 in 2019 through the third quarter. The second row is really the thing that we're most concerned about. What was the pregnancy outcome of those cases? And blue represents the outcome we want, which is that the congenital syphilis case was averted and that the pregnant woman was able to be treated effectively. The orange represents a case of congenital syphilis, and the green, at the time that this data were made into this graphic, green represented someone who had been treated but was still in the pregnancy, had not delivered the baby at that time. But we expected that at the time of delivery, this would not be a congenital syphilis case and the circle would be blue. But as you had heard so clearly from Dr. Seidman, when we look at it this way, the associations and the multiple vulnerabilities become very important. And we see that the people that were cases or people that were experiencing homelessness, people who were lacking prenatal care at the time, and particularly people that were reporting using methamphetamines, were all highly associated with cases of congenital syphilis. So this helped direct our understanding of the types of work that we would need to do together in order to try and address congenital syphilis in San Francisco, and also helped us understand and prioritize what our next steps might be. So what did we accomplish by doing this? It wasn't everything, but it was a good start. And it really allowed us, again, to bring people who were not experts, not thinking about this every day, into this work to assist us, but to also think about how their home departments and areas might be able to contribute to the work. So one of the things that I think was really, really wonderful that came out of this was a partnership with DPH and UCSF, Team Lilly, and Dr. Seidman's team to better serve pregnant women with barriers to traditional prenatal care, and to use some of the grant funding that we had through STD to be able to support that team's amazing work. The team and the data also helped support and work with other city departments and advocates to try and advocate for accelerating housing for pregnant women with syphilis. And I think that conversation continues to be ongoing. There were new initiatives for rapid syphilis testing in our jail health population and in street medicine, which, the teams there did an amazing job of really incorporating this into their standard work, which was really wonderful. And then again, establishing the multidisciplinary case conferences to review missed opportunities in congenital syphilis cases. The other things that happened that were notable are that we were able to, with the community branch, field test information and approaches with women experiencing homelessness to really find out, what color they liked best on a flyer or on a card to explain where they could access testing and screening and the services that were available to them. We were working really closely with the acute care hospitals, Zuckerberg San Francisco General Hospital and their emergency department and urgent care to really try and measure and improve and have a quality improvement approach to screening for women who came into those areas of the health system. But, we were limited during the time that we were working on this in 2019 because there was a big push to put an entirely new electronic health record, EPIC, into place. And so a lot of staff time and energy and the data analysts' time and energy were really spent on validating that new system and building that new system. And then we have these new quarterly standardized EPI reports that focus on syphilis in women. And the chart that you saw that Hannah developed is part of that ongoing. And then there are other very nice visual representations of the data that help us and help inform the current state of the EPI, but also how our work is having an impact or not. There were a lot of lessons learned and challenges in doing this work. The structure of ICS, first of all, is really helpful and was very helpful in congenital syphilis response, given the multiple and complex contributors that were clearly present. Up front, to actually have us move into ICS, it was our epidemiologists' very clear and compelling organization of the data that established the need to act. So the program leadership, STD leadership, and our epidemiologic epi leadership really came together with this epidemiologic data to be able to talk with our health officer and talk with our director of health to get buy-in. And then once we were in ICS, that entire process was able to help us communicate the urgency, that there was strong leadership buy-in. And so all of that was very helpful in getting traction and getting conversations going much faster than they would have been with me or others going one by one to different areas of the health department. But having said that, we were certainly not ICS experts, and we needed the strong commitment. We were so grateful for our colleagues in public health emergency preparedness who really were the ones that kicked us off and kept the format going. They staffed plans, they staffed incident command, and really assisted in this work. But we saw, that there were still competing priorities. The EHR was one of them, and there were others as well. And even prior to COVID-19, it still was a lot of energy required from everyone in order to keep this work moving forward. So we completed 2 12-week periods, activation periods, and had a break for the holidays. And we were in the process of not continuing that specific mode of doing work and continuing ICS, but moving to a new sort of shared problem-solving approach and then COVID emerged. And I think that we saw that what ICS did was that it allowed us to get the buy-in, get the interest, raise the visibility enough that we could move into this secondary sort of shared approach to problem solving and doing countermeasures to what we had already identified as some of the gaps in our system. And, we're going to need to continue to work on this because unfortunately in 2019, our cases continue to increase, and that's been true for the first part of 2020 as well. But of course, now we are in a whole new ballgame with a citywide and long-term activation for COVID-19. And many of our enhanced syphilis prevention activities, unfortunately, are on hold. A lot of our STD staff are activated, about a third overall, including almost all of our leadership. So it speaks well to the effectiveness of our GIS and of our STD leaders, but it also remains a challenge to try and also continue this very important activity also. But, our goal and our hope is that we're going to take these opportunities of incoming resources for COVID and use them for longer term prevention gains in all of communicable disease. So this could include staffing, laboratory equipment, but then also more generally, a public and policymaker understanding of the work. What are we doing when we are intervening and calling people as DIS, when we are planning out what a response should be? I think it'll be much more familiar in people's minds in San Francisco as a result of COVID. And we need to make sure that we don't lose that and squander that opportunity when we turn back and are thinking again about a congenital syphilis in a very enhanced way. So I want to thank you all again for the invitation and the time to share with you, and look forward to having more discussion around this. Thank you.
Our fourth and final speaker is Jenna Slutzker. Jenna obtained her Master's of Public Health degree from the Yale School of Public Health. After graduation, she completed the 2-year CSTE Applied Epidemiology Fellowship at the New York City Department of Health and Mental Hygiene, and continued working at the agency, moving into the Bureau of Sexually Transmitted Infections in 2016, where she continues to work as a research scientist. She has worked on a number of disease control investigations and research projects, focusing on understanding and preventing transmission of infectious diseases, including syphilis and tuberculosis, to children. Over the past 2 years, Jenna has worked as a primary analyst assessing congenital syphilis prevention in New York City.
Thank you so much for the invitation to speak today and for the introduction. And because I'm not able to share video, I wanted to start with a picture of myself as well as my contact information for any follow-up after the presentation. In terms of a brief outline of what I'll be discussing today, I'll be starting with some of the background that led us to develop a congenital syphilis prevention framework, which I'll be discussing today. And then I'll be walking through our data collection and classification process. Next, I'll move into showing a few different visualizations of our congenital syphilis prevention framework, and then I'll end with sharing how we've applied these findings to mandate third trimester screening in New York City. So by way of background, this graph shows primary and secondary syphilis case rates for males shown in blue and females shown in teal in New York City from 2000 to 2019. You can see that we have substantial increases, especially among males across this time period, and that in 2019, males accounted for close to 95% of all cases. However, we have observed slight increases in female syphilis beginning around 2016, and because increases in female syphilis often precede a rise in congenital syphilis, this prompted our Bureau to have a renewed focus on congenital syphilis prevention. Around the same time that New York City started to observe these increases in female syphilis, there was growing national discussion around syphilis screening laws during pregnancy. And back in 2016 and through present day, key national organizations have recommended that all pregnant people be screened for syphilis when they first present to prenatal care. And these organizations also recommend that pregnant people who are at risk for acquiring syphilis during pregnancy receive additional screening during early third trimester and at delivery. The recommendation for universal syphilis screening in early pregnancy is required by law in most states, including in New York, where screening is required at the first prenatal care examination and at delivery. There are fewer statutory requirements around third trimester testing, but as described in the pictured publication, several states have responded to the recent resurgence in congenital syphilis by mandating third trimester testing, and you heard about Louisiana a little bit earlier in the symposium. The last event that encouraged us to revisit our congenital syphilis framework was the prevention cascade that Sarah Kidd first presented in 2016 at the National STD Conference. And the objective of her analysis was to visualize the essential services that are required to avert a congenital syphilis case, including prenatal care, syphilis screening, and adequate treatment, and to identify opportunities to strengthen prevention. In the CDC framework, they use national data to estimate the percentage of pregnant women with syphilis who received each essential service at least 30 days before delivery. Overall, you can see that these percentages are high. However, they still identified areas for improvement, such as shortening the time between testing and treatment. One limitation of this analysis was that it used national surveillance data on infants with congenital syphilis and their parents, and these are de-identified and unlinked. And so we were interested in if we could adapt this cascade for a local context where we have more detailed data available. So in pursuit of building a local congenital syphilis prevention framework, we started with a broad review of clinical and public health data related to congenital syphilis cases. In this next section, I'll be describing our process for collecting these data and ultimately classifying them into a holistic framework. So we started with all information collected during surveillance and case management efforts. And these records in New York City are stored in one syphilis registry, and we use Maven, which allows for saving attachments. So we had a wide range of data sources, including copies of medical records and notes from partner services interviews. From Maven, we abstracted demographic, diagnostic, and case management data for every infant with congenital syphilis and their parent. And then we reviewed these comprehensive data to determine the main missed opportunity that led to each congenital syphilis case, with a focus on the same pathway described by CDC, which involved examining prenatal care, syphilis screening, and treatment, and determining whether these occurred early enough in pregnancy to prevent a congenital syphilis case. And I'll get into how we defined early enough a little bit later in the presentation. We were particularly interested in developing a framework that highlighted actionable missed opportunities. So looking at opportunities that could lead to programmatic or policy changes within our work as a health department. So in the next few slides, I'm going to walk through a simplified version of the template that we use to review congenital syphilis cases with showing a few case examples. So our first step is to abstract delivery date and last menstrual period date. And last menstrual period date is often missing in our surveillance and case management data, in which case we'll estimate this using standard methods used by OBGYNs. From there, we calculate relevant time points for congenital syphilis prevention, including 30 days before delivery, which is the point at which a pregnant person needs to initiate treatment to prevent a probable case. 45 days before delivery, which is the cut point that we used locally to define or as early enough for prenatal care and syphilis screening to be received in order to prevent a congenital syphilis case. And this is one part of our methodology that required some consideration and discussion. So I just wanted to stop and elaborate a little bit on how we arrived at 45 days. So we selected 45 days because it allowed for a 15-day window before the 30-day cut point when treatment initiation is required. And we thought 15 days seemed like sufficient time to get a positive test, contact the pregnant person, and hopefully initiate treatment. This time frame also was aligned with other frameworks that other jurisdictions had published recently. The last time point that we calculated was early third trimester, which is the window where additional screening is recommended for pregnant people who are at risk for acquiring a syphilis infection during pregnancy. After establishing the dates of interest, we then reviewed the first essential service, prenatal care, by searching all available records to see if there was at least one prenatal care appointment 45 days before delivery. In this example, the person had documentation of prenatal care, so we would move on to the next essential service of syphilis screening. Next, we categorize whether syphilis screening was received 45 days before delivery, and if so, the test result at that time point. For pregnant people whose only known test at 45 days before delivery was negative, which is shown in this example, we would then assess receipt of third trimester testing. And for this pregnant person, there was no third trimester test. For this individual, we would then categorize the missed third trimester test as the main missed opportunity. And this is because we're classifying from the perspective of the health department with an eye towards how our programs can be strengthened. And in this case, there's little we could have done in terms of downstream prevention because we would not have been aware of this syphilis infection until close to delivery. And we would be kind of thinking about what would be our health department next steps for this missed opportunity, and it would be things around efforts around improving third trimester testing. I also included this final column, which is entitled Summary here, to just show an example of a notes field that we use to track syphilis titers and key findings during pregnancy. And I wanted to include a simplified version here because this is often where we had our kind of first insights or patterns emerged when we were first doing this classification process. I wanted to provide one other example of a congenital syphilis case review. So for the second pregnant person, again, we start by using delivery date and last menstrual period date to calculate these cut points across pregnancy. After examining all available data, it was determined that this pregnant person did not receive prenatal care 45 days before delivery. And so while we're interested in syphilis testing and treatment for surveillance and case management purposes, for this framework, we jump immediately to categorizing the main missed opportunity as late or unknown prenatal care. And this is again because the objective for this was not only to identify missed opportunities, but to inform our health department efforts. And for someone without access to care 45 days before delivery, important health department actions would be related to advocacy for increased access to health coverage and care for pregnant people. So after reviewing all pregnancies that resulted in a congenital syphilis case, we narrowed down to a framework that included 4 major missed opportunities for congenital syphilis prevention. We'll be highlighting a few different visualizations of this framework in the next few slides. So in this first visualization, you'll see a flow chart showing the missed opportunities chronologically across pregnancy for congenital syphilis cases in New York City from 2010 to 2019. So the first essential service that we reviewed was prenatal care, and we found that around 25% of pregnant people did not receive care at least 45 days before delivery. This was our first main missed opportunity, which is highlighted in the blue box. Next, we examined receipt of syphilis testing, and we identified 6 pregnant people who received timely prenatal care but were not tested for syphilis. They are highlighted in the pink box. We then looked at the results of syphilis testing, and there were 44 people who had a timely negative test who subsequently acquired syphilis during pregnancy. The majority of these individuals, 66%, which are shown in the purple box, were not tested in early 3rd trimester, which might have detected a recently acquired infection. Finally, we reviewed treatment data for the 30 pregnant people with a positive test 45 days before delivery. There were 8 people who either didn't receive treatment or treatment that was initiated less than 30 days before delivery. That's our final missed opportunity, which is shown in the gray box. The remaining 22 people initiated treatment 30 days before delivery, but had tests close to delivery indicating reinfection or persistent infection. So this flowchart represents our standard way of viewing this framework, and we've found it helpful to kind of view these missed opportunities along the pathway throughout pregnancy, but we have looked at these data in a variety of ways to better understand opportunities for prevention. This graph highlights another approach where we evaluated the proportion of cases related to one missed opportunity across time. So the teal boxes here are showing the number of congenital syphilis cases in New York City in each year, and the blue line shows the percentage of cases related to syphilis acquisition during pregnancy. So this isn't a linear trend, and it's hard to be with such small numbers, but in the last few years, 2017 through 2019, over 50% of our cases were among pregnant people who tested negative early in pregnancy and then acquired syphilis during pregnancy, with many of them not receiving a 3rd trimester test. So this observation, in addition to growing national interest in 3rd trimester screening, prompted us to explore universal 3rd trimester screening in New York City. Our first step was to investigate the acceptability and feasibility of mandating 3rd trimester testing in New York City. So we first sought the input of partners across the city and the state. And to just describe a few examples here, we spoke with providers at a large public health system here in New York City, and they informed us that they already had a universal 3rd trimester testing policy, and that they had, when they described the implementation of this, they had experienced pretty limited administrative challenges with implementation. We also reached out to our colleagues at the state health department and learned that they were also seeing missed 3rd trimester testing as a major missed opportunity for congenital syphilis prevention. And so we've been able to work closely with the state on 3rd trimester screening and policy. And so that's been a great partnership. Our next step was to present our framework findings to the Commissioner of Health, and she urged us to propose an amendment to the New York City Health Code requiring that providers rescreen all pregnant people for syphilis in early 3rd trimester. So we moved forward with this by drafting language for a mandate, as well as a justification for pursuing universal third trimester testing, and both of these were shaped by the findings from this framework. So we proposed the amendment in June 2019. It passed in October, and as of November 15th, 2019, New York City healthcare providers are required to test pregnant persons for syphilis at 28 weeks of pregnancy, or as soon thereafter as reasonably possible, but no later than 32 weeks of pregnancy. The test results and a treatment plan must be documented in the patient's medical record. And I just wanted to note here that when we were going through this process of passing this through the Board of Health, we received one letter of support from the state health department and no letters of detraction. So since the adoption of this mandate, we've continued working hard on provider education efforts and developing plans to evaluate the impact of the mandate on syphilis screening and congenital syphilis prevention in New York City. So in conclusion, structured review and classification of our congenital syphilis cases in New York City was a valuable activity, not only for understanding factors that contribute to our burden of disease, but for identifying and advocating for improved essential services in the city. So thanks so much for your attention. I wanted to acknowledge all of the people on the slide who work on congenital syphilis in New York City. Robin and Julie are two people that I work with very closely, and then we have our congenital syphilis work group that meets quarterly to review cases and has informed all of the work that I presented today. Thank you.
Thank you, Ms. Slutzker. That is our last speaker for this session. I want to thank all our speakers today and the audience for your attention. I want to remind you that there will be a live question and answer session for the symposium on Friday, September 18th at 4:10 p.m. Thanks for your time. Take care.